السلام عليكم ورحمة الله وبركاته جميعا. بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه وسلم تسليما كثيرا. First of all, thank you, Mr. Chairman, for the introduction. Thank you, Dr. Adil, for the kind invitation. I always called the ICU staff are the warriors, because I've heard today it's going to be another 6-hour shift for you. I'm not sure if this would be added in your schedule. So hopefully this course will be fruitful, as said by Dr. Adil. Inshallah, this topic will be very simple, very informative, because at the end you are using this guidelines for all your cases, and also when you do different management for different patients, you came across guidelines. So we will start by the first thing, which is common in ICU. So use of hypothermia in critical care. So there was an international consensus conference on hypothermia in cardiac arrest, in hypoxic newborns, in stroke, and myocardial infarction. But before going and try to understand further the guidelines and systematic reviews and everything, just let's go back to the basic and remove the dust from the old-time school. So if you remember, in the to come up with any evidence in clinical practice, we have to know that evidence came from where. Was it a cohort study? Was it case control? And if this is the case, then this is under the observational, and this is what we call analytical. And analytical then under the quantitative, and this is under research. So research can be divided into many different subcategories. One of them is called also descriptive, when you have a case report, case series, and sometimes cross-sectional. So cross-sectional is when you have a target population, all variables are measured in single point time. So each study has different limitation and different advantages. We will not focus on each type, but we will tell you just this is one of the example of how the evidence comes from. We do also have case controls. So back with cases, common cases, let's say lung cancer, and then go back in time and then see if were exposed to shisha or no shisha. So this is what we call a case control study. When we say prospective, so people who are smoker, we followed them on time and then see if that group developed lung cancer, and if they did not develop lung cancer. This is what we call prospective, and remember that there is no randomization. When we say randomized controlled trial, so we have patients with MI, let's say, for example, and we randomize them. The key thing here is randomization to either drug A and drug B, and then follow the outcomes. So the advantage of randomized controlled trials is to figure out the known and unknown prognostic factors. So we came across all these studies, and you can see sometimes while you are in the ICU trying to manage a patient, somebody can come to you and say, let's start the patient on this protocol or this drug. When you try to find the evidence, sometimes you can see some people say, well, this is based on my experience. And when you look at the evidence, based on my experience is based on the bottom of the evidence. Opinions, ideas, and anecdotal finding. When that person say, well, this depends on a case report that I came across. So you see, it is still in the bottom of the evidence compared to observational study in the middle and clinical trials, which is in the top. But the best and highest evidence are systematic reviews and meta-analysis. So each study, you have to know about two things. Number one, what is the quality of that study in terms of methodology? So the procedures, the steps the researchers did to find out the best quality to deliver that research, or reporting the quality. Okay, so provided information were reported in good quality. I think now we can, after reviewing the research categories, now we're able to talk about grade. So what is grade? So grades of recommendation, assessment, development, and evaluation. So there is an online tool you can use, and also there are many other tools who are using the grade. For instance, the most commonest one all of us are familiar with is UpToDate. They use grade. If you do systematic reviews, you know also about the Cochrane, BMG, and so on. So to put this in a simple word, what happens when people are trying to give you a guidelines? So this slide looks busy, but at the end, what they're aiming to do is to provide you a simple, systematic, transparent information based on the outcomes and based on the quality of reported studies. So for instance, in any research from the past till now, till the future, the main focus is number one is the PICO, population, intervention, comparator, and outcome. So they have to select which outcome is good. And based on that, they found papers and they try to collect the outcomes. And then they have this tool, to put the summary of the findings. And then they have to check, is this outcome based on the quality? Is it high quality, moderate quality, low quality, or very low quality? You know from the previous slide I showed you, the pyramid of research is systematic reviews in the top, case reports in the bottom, my opinions is in the bottom of the list. And based on that, these people who are the panelists, who are the most experts in their fields, they will sit together and try to rate the overall quality of the evidence. These panelists then will formulate a recommendation, either to say, well, we recommend, or we are against, or maybe this is strong or this is weak. And then considering quality of evidence, benefits and risks, values and preferences, and also then the final draft of that guideline will say we recommend using, we suggest using. You see the difference between both recommend and suggest, or we recommend against using, or we suggest against using. To go deeper, so this is great, we talked about it. So in each guideline, they should include a clear question. So when you want to come up with the guidelines, and I'm sure in the past 5 years, I came across many consensus and guidelines in the ICU, especially during the COVID-19. So they have to have select the patient's intervention, comparator, and outcome. So the same old thing, which is PICOT. And then number two, they have to find the outcomes of interest. For example, somebody who has, let's say, mortality. Mortality, you would rank it on the top, number 9. You have somebody with myocardial infarction, you will rank it number 8 probably. And so on when it is, you have not important or least important outcome. Not only that, for instance, if you're dealing in the ICU with somebody with lymphoma, and that patient, you can argue with your fellows or residents, or even the consulting service, should we give the patient GCSF or no? So you have to know, based on this, is this a critical thing? Is it important or less important? So what's critical and important if the GCSF is improving survival? So this is the benefits we call. If it doesn't, then what is the side effect or the risk or the harm? So it can cause rupture. It can cause thromboembolic complications. So these are what we call risk and benefits. It's critical for our patients. Compared, for example, if we say reduction in hospitalization costs, so is not that important from a physician perspective or even patient perspective, but this could be less important from the administration perspective. The second important thing about guidelines is when you try to judge the quality of evidence. So you can say that evidence or that paper or that guidelines is important in this particular context. You cannot apply it for all patients and all outcomes. The second thing, when you try to apply that evidence, you have to have confidence, and confidence can be measured in different ways. So this is what we call the estimate effect, and we will come to this in a few slides. So as we said, the best thing when you come across guidelines is that guideline based on RCT. So this has highest or strongest quality compared to observational study. As we showed, it has low quality. Now, 5 factors lower the quality of evidence. You don't have to go that deep, but this is just to give you an idea how come and from where we get the evidence. So you have methodological limitations, inconsistency, indirectness of evidence, imprecision of results, and publication bias. All of these should be counted when you recommend for or against specific treatment or protocol. An example for methodological limitations. So lack of allocation concealment. So sometimes when people do randomized controlled trials, you can expect the allocation of next treatment. You're not using computerized way of allocation. There is no blinding. So the doctor knows exactly he's giving the drug A versus placebo. So this will reduce the quality. Yeah, you have loss of follow-up in many articles. So you don't quote RCT and you don't go deep and find how many people enrolled and how many people were able to finish the trial. How many, the percentage of patients who lost follow-up. And also if that clinical trial was stopped early, either for benefits or due to harm. Sometimes you have failure to report the outcomes. So all of these can reduce the quality. When we talk about inconsistency of results, we mean heterogeneity. So what we mean by heterogeneity, all of you come across this plot. So you have to look at the confidence interval. The shortest or the narrowest is the best. The longest are not the best. This is number one. Number two, the size of that triangle or that square. So for this example, so you have very hard, well, a very narrow confidence interval here and very big square. So this means you have a lot of events or a lot of information favoring endovascular surgery, for instance, in this group. Second, you have to look about the last diamond here. Is it favoring this intervention or that intervention? If it's one, then probably this is not useful. Last thing, you have to focus on the heterogeneity, which is I2 here. The highest would be highest heterogeneity. I mean by that, I can show you a slide. So less than 40% is low. If it's 75 to 100%, then this is considerable heterogeneity. Heterogeneity means you have different group, different population, different treatment, population, intervention, outcome is different. And sometimes the study methods are even can affect the heterogeneity or inconsistency of results. Like what you see in this curve here, you see, you expect to find the confidence interval and all squares in one part, either in the left side favoring sclerotherapy, for an example in this case, or in the right part. But when you see it in different picture in the left, crossing one in the right, left, right, then you see there is a problem here, inconsistency of results. In contrast to this one, you can see this paper, all of these squares on the left side, except this one. So this have good heterogeneity. Next thing about the factor, indirectness of evidence. So this is require judgment. So you have to judge that paper. And this is based on what outcomes are you using. Are you use indirect, for instance, surrogate endpoints in the trial? Or there is an indirectness between the study or applicability. I can give you an example in this case. So you can see, for instance, when you talk about diabetes, so patient important outcome is what? Let's say symptoms, hospital admission. But what is the surrogate? Surrogate outcome could be A1C or blood glucose level. So indirect evidence. Another way of saying indirect evidence is the when you don't have head-to-head trial, and this is happening in ICU and in oncology and cardiology and everything. So you have drug, you know about the trial, drug A is better than B. You know, drug B is better than A, but you don't know what about drug C. So we have to do sometimes what we call network meta-analysis to overcome this. Applicability is another problem can affect the population of interest, but always the guideline panels frequently look for the applicability, that evidence is applicable or not applicable in our population. Imprecision, we talked about, it depends on the estimate effect. And imprecision can be because of maybe sometimes you have lower event, so people are still alive, did not develop the outcome you're trying to report. This can downgrade the imprecision and confidence in estimate effect not adequate to support decision. This is an example. We said, you see, you have the wide confidence interval, and you have good event till now, and did not cross the boundaries. So you have smallest clinically important difference compared to this one. You see, there is no downgrade here, but here, because it's crossing the boundaries, then yeah, it can affect the quality. The last thing is publication bias. You know, trials are sponsored sometimes by pharma industry or sometimes by investigators. And it is used to be a non-factor that if you have negative trial, people will not be willing to publish these data. So as we said, RCT starts high always, observational study start low, but what raises the quality of evidence? Another question. So when you have large effect, so you know this drug A is better than drug B by 50%, 60%. And also you count it for the confounders that sometimes can affect, for instance, age, smoking history, presence of comorbidities. All of these, when you count it for, then you can raise the quality of evidence when you have the counted or adjusted for confounders. Now, after they went through this long, extensive process, reviewing all evidence, the quality and everything, then at the end, they have to put number 1 and number 2 together. So for example, you have randomized trial and the study limitation is serious. You have to put number 1. If it's very serious, you put number 2. Higher if there is large effect, lower if it is number 2 if it's very large, and so on. So this is how they grade it, and based on that, you come up with either high, moderate, and low, and very low quality. Sometimes when they say strongly recommended, so they mean that the recommendation will cause more good than harm. So this is why they strongly recommend. So I think the bottom line here, when they strongly recommend, then if you don't use it, then probably you're not following the best practice. But when it is weak recommendation, so they call it suggestion. So if you don't use it or you don't follow that guideline, then probably you can be safe if you have good reason or justification. How they present that at the end, they say do it or don't do it. Probably don't do it. The quality could be high, moderate, low, or very low. That's the explanation. Sometimes they put numbers. So recommendation 1 means strong, 2 means weak. A quality A is better than B, than C, than D. And sometimes they put symbols like 2 up, plus, plus, plus. And back to the hypothermal protocol, you see, they prioritize the PICO. They establish a panel, and then they perform a systematic review based on PICO. They summarize the evidence in table. They judge the outcome that are critical for them. And then they judge overall quality of evidence based on what we have discussed. And they judge the balance and benefits. Also, they generate recommendation. And then you come with the strength and recommendation. So the population hypothermia, they talked about traumatic brain injury, not sure about concussion, confusion, hemorrhage, subdural, etc. Intervention, exact temperature 23, 32, or 35. And then comparator was regular care or normothermia, and we're not sure about the outcome. It's like an exercise you can do and follow it. So you know about these outcomes. Are we dealing with Glasgow Coma Scale, mortality, duration in ICU? And all of these can be seen or looked at in very old Cochrane systematic review, and you can see the difference in estimate effect with confidence interval and the square. And then the last thing is the heterogeneity, which was 8%. So it was more or less consistent or low heterogeneity. And then you have some source you can, it's actually established by those people. You just go inside these tables, you fill the information. And these are the websites you can use and follow as a practice, so you know exactly what happens. And this is how they look inside that tool and the online version. And at the end, if you can see, they recommend not to use, and this is called traumatic brain injury 1D. So it is strong but little quality. 2D, you're away. 1D same, 2D same. And we offer no recommendations. This is how they reach to this. And thank you.